I'm Jacob Lancaster. I'm here to talk to you about ACLS, which is Advanced Cardiac Life Support. So most people are have had BLS training of some sort and know how to do CPR. Advanced life support is even more advanced for a more acute setting where you have the things that you need, such as drugs and a Zoll, to do even further intervention in cardiac life support. So first I'll be talking about BLS and some things that people skip. Then I'll be talking about what devices we use for BLS and ACLS. After that, I'll go into the arrhythmias and the algorithm that we use to try to bring someone back to life, essentially. So first, when someone is found unresponsive, their heart leaves a normal sinus rhythm, which is what most people have, and goes into VTAC, VFib, which are the two arrhythmias we'll be going into, but there's further arrhythmias that we'll skip over for just the time being. So first thing that they do is they see someone unresponsive and they feel for a pulse for 10 seconds. This is all BLS without even getting into ACLS yet. If there's no pulse, they begin CPR. And it starts with ABCs, airway, breathing, circulation. So the first most important thing is to make sure the airway is clear. Then you can begin breathing either with a bag mask or something else, and followed by that, chest compressions. So Braden here is going to demonstrate. We use a Zoll, which is a machine that will show a rhythm when hooked up. Come on up. The Zoll has pads that we put on the patient that goes in the upper left side and the lower right side. This helps us determine which rhythm they're in, and likely they're in one of these two rhythms. So the first thing they'll do is follow an algorithm. So the patient's found unresponsive, they'll begin CPR and see if the rhythm is shockable. These two rhythms below are shockable rhythms. So if yes, we go ahead and shock. The Zoll itself will be programmed starting at 200 and go all the way up to 360 for voltage for shocking. After that is shocked, you continue CPR. And after 2 minutes of CPR, they'll stop and do a pulse check. If you feel no pulse, you look at the rhythm. If the rhythm is one of these pulses that's still able to shock, we'll turn up the voltage on the Zoll and go ahead and deliver another shock to the patient. They'll continue CPR again, and if they still haven't returned to a regular rhythm, we'll go ahead and give 1 milligram of epinephrine. Epinephrine is essentially a vasoconstrictor, so all your arteries and everything in your body will constrict, helping your heart receive more oxygen into your bloodstream. Again, after 2 minutes, everybody will stop, we'll check a pulse. If it's shockable, we'll deliver a shock at 360, which is the highest the Zoll will deliver. And then continue CPR again, and if they still continue to enter this deadly arrhythmia, either VTAC or VFib, we'll start amiodarone. The first dose of amiodarone is 300 milligrams. Amiodarone is essentially trying to get the heart back into a regular rhythm. Now say we were to start CPR and the rhythm's not shockable. That would be considered asystole or PEA. PEA is pulseless electrical activity. So if we see that, we'll begin CPR for 2 minutes, and then after 2 minutes, we'll stop CPR, check pulses, and also look at our Zoll, which shows us which rhythm they're in. If they're still in PEA, we'll give them the 1 milligram of epinephrine and continue CPR. After 2 minutes, if they're still unable to shock them out of a rhythm because they're in PEA or asystole, we continue CPR and give epinephrine 1 milligram every 3 to 5 minutes. After about 15 to 20 minutes, if we still haven't returned ROSC, which is return of spontaneous circulation, we'll start going through H&Ts. H&Ts consist of hypovolemia, which means you don't have enough fluid in your body to maintain a blood pressure, which put you into cardiac arrest. Hypoxia, which would be little to no air, so you get very short of breath and your heart's not getting the oxygen it needs to continue to beat, putting you into one of these arrhythmias. Hydrogen ions, which is acidotic, if your heart gets any little bit acidotic, it hates that environment and can go into one of these arrhythmias. Hypo or hyperkalemia, which is too much or too little potassium. Potassium has a great impact on the heart. It's an electrolyte that the heart uses the most. Hypothermia, if you become too cold, your heart can go into sudden cardiac arrest. And a tension pneumothorax. So after going through all these, we'll try to determine what put this patient into the arrhythmia. Sometimes it could be low blood sugar, and they went into cardiac arrest and unresponsive. It just depends. In an acute care setting, we do everything we can to try to eliminate having somebody go into this, and if they do go into one of these arrhythmias, we do everything we can to get them out as fast as possible. A longer downtime has lower odds of survival. So, I hope the next time you have to use ACLS, you're in a situation that you have these things available to you, and also that you achieve ROSC.